The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Hi, George. It's Tuesday morning, and we're going to record a great podcast with someone in Nebraska.
Yes.
Middle of the country.
Today, I'd like to welcome Dr. Sian Jones. And the title of the discussion is going to be, Let's Talk About Value-Based Care and How It Pertains to Pediatrics. It should be a very interesting topic since everybody's talking about value-based care. Yet when I ask people, what is the definition? Everybody's clueless. Take it away.
Dr. Jones is passionate about excellent pediatric and adolescent medicine. She has dedicated her life to fostering healthy, supportive environments for her healthcare team members and their families they serve. And motivated by over 20 years of working with patients, families, students, residents, nurses, staff, and advanced practitioners and fellow physicians. She believes in physician-led healthcare, which is focused on building positive relationships with patients, families, and all her healthcare team members. Welcome, Sian. It's a pleasure to have you on the podcast.
Thanks. It's a pleasure to be here.
You have accomplished quite a bit. We don't have enough time to go through all the things you've accomplished out there in Nebraska.
Yeah.
But why did you become a pediatrician?
I actually started out medical school thinking that I wanted to be an OB-GYN, but I really enjoyed both the people and the patients and families in pediatrics. Some of my best mentors were the pediatricians I worked with and the staff that work with kids. They're just a different breed of people. I really enjoyed it, and it became obvious by the end of my med school career that's where I wanted to be.
And then let's level set a little bit because you have not only a very large group, but a phenomenally integrated group. What does your medical home, your practice look like out in Nebraska?
So we have 4 offices, and one of the things that our founding pediatrician did when we first started our practice was put his first office in one of the more underserved. Most of the medical facilities were central to south, and he went all the way to the north part of town to the very edge where there was almost nothing and parked the first practice. And that was about almost 27, 28 years ago. And from there, we built up to 4 practices, and we basically surround the city of Lincoln. Lincoln's about 350, 400,000 population city, and then it serves all of the communities around us. So we're the main facility for the surrounding communities. And we have 16 pediatricians, 6 advanced practice practitioners, and then 6 PhD level psychologists integrated into those 4 clinics. We do integrated behavioral health. We do integrated asthma clinic and do monitoring for asthma. There's a shortage of people who adequately and correctly see pediatric asthma patients in our area, and we do that. So we really do the full gamut of pediatric care. We have acute care clinic on the weekend, Saturday and Sunday, and we have evening clinic several days a week.
The founding pediatrician established the culture.
Yes.
That's exactly what happened in our practice 50, 60 years ago. In an area of Long Island that's lots of commercial insurance, Dr. Reichman insisted that the practice take Medicaid because we cannot exclude children by their insurance. And that thing has grown. So we used to think that, okay, Medicaid will see the children. It'll be subsidized by some of the commercial payers. It wasn't such a big line of business at that time, but we had to take care of those kids. And that culture went forward.
I have a lot of questions about your practice. Number one, when you say, because I think you do mental health, you do obesity, you do asthma, how do you manage these? Are there separate chronic disease clinics that you run for these populations?
Yeah. Prior to COVID, we had separate clinics. So we would have certain physicians who that was their niche area. They did more training in it, who would have days of the week or half days of the week that were set aside for managing these chronic diseases. COVID changed everything. So one of the things we recognized when we went back to it is that we were missing care opportunities for patients because they couldn't necessarily make those days of the week work. In addition, those days weren't always efficient because sometimes we would have no-shows or late cancellation. Then it would be difficult with the flow of those clinics to try to integrate other patients. We would do it, but it never worked very well. And so what we decided to do was have these clinics without a clinic. So we just integrate those patients with the appropriate amount of scheduling into our schedules. My schedule, like most pediatricians, has asthma patients sometimes, behavioral health patients, and childcare sometimes. We have, each of our physicians has an LPN or RN primary care clinician. And so that's who we have on the floor, taking patients back and interacting with patients. And then they do the care management in between patients. We do 4 days a week in clinic as general pediatricians, and the nurses can do 4 days a week plus a flex day to do some of their care management.
And so for the asthma kids, do you do pulmonary function tests in the office? Yeah.
Yep. So we do spirometry right now, but not exhaled nitric oxide. But we do spirometry. And that was one of the reasons why we used to have separate clinics, was so we could set up the spirometry and have an extra staff member there. And one of the things we also noticed with that was we weren't always able to do it on the spot when we wanted to do it. So if I saw a kid in clinic with a complaint of cough, and mom comes in and says he's had cough for 4 months, and it sounds like he's actually had recurrent wheezing in the past, I can do pre and post spirometry right there and make a diagnosis right there without bringing him into asthma clinic first. And I don't have to delay starting a controller therapy worried that it's going to affect their spirometry. That was one of the good things, I think, for our clinic that came out of COVID, was we changed the way we thought about that and now do on-demand testing.
And then do you have over 4, they're older than 4. Do you have them all in smart therapy now with an inhaler, or?
It depends on the patient and their insurance coverage. To be frank, getting the smart therapy covered for all of our patients has been difficult because they don't want to cover the appropriate inhalers. Also, if we have kids who are already completely stable and well managed on their plan and their parents are doing a good job of managing them, changing them, in my mind, doesn't make sense, especially if we have to work on a lot of prior auths and those kinds of things. So most of my new diagnoses and patients that I'm managing, I'm putting on smart therapy. The older ones that are well controlled, usually not. And if insurance gets in the way, which seems like it happens a lot of the time with our payer mix, then we don't. We did fight pretty hard with, actually, I couldn't say it, fight pretty hard. That's probably an exaggeration. We did work diligently to get smart therapy covered by our Medicaid plans. So we're not having any trouble with that. And that really has to do with the fact that we had a smart pediatrician in Omaha that we knew, who was on the P&T committee for Medicaid. And when we sent him the information, he just said, yeah, the next meeting we'll add it to the list, and boom, it was covered.
And to you, I still use a lot of nebulizers, and one of the pulmonary doctors says, there's no need for it. I like to see the kid actually use the spacer in the office.
Yeah, we do that.
Just make sure that, because every kid's different. Some 4-year-olds can do it. Some 6-year-olds are so distracted, especially the boys, they can't take 10 breaths in a row. It's just like giggling, they're laughing, and you breathe all day long. Just breathe. And then giggle and laugh. But
we do only MDIs pretty much in the clinic. We have nebulizers, but we pretty much only do MDIs.
Consider any patients with diclofenac that have the eczema, the asthma, and the allergic rhinitis, and they're difficult to control?
If they're difficult to control, oftentimes then we will send them to either pulmonary or asthma allergy. We do have that resource. We find that if we try to get that approved just on our word, we have a hard time getting it approved. And so if we get a one-time visit with asthma allergy or pulmonology and they say yes, then we can get them on it. So that tends to be our specialty.
So to me, you're a real pediatrician. Yes. You're taking care of real medicine. And then on the obesity side, how do you manage that program? Because the guidelines from the AP are 1 visit once a week for an hour for intensive therapy.
Yeah.
That's just not possible.
It's we don't have the resources, the manpower to do that, right? Like I don't have the pediatricians or APPs to actually manage that. I can't get the insurance companies to pay for other people to do that education, to pay for it adequately. So even if I trained a nurse to do it, I wouldn't get paid enough to make that worth its while. I can't get nutritionists paid for. I can't get physical therapy or a personal trainer paid for. So all of that stuff that's in there sounds great, but it's not practical when it comes to both payment and resources.
These things are designed for academic centers.
They are. We have 2 academic centers. I don't know if you'd call Boys Town an academic center, but it is a pediatric specialty care facility in Omaha and then Children's Hospital in Omaha. They both have pretty well-established obesity programs. The problem is none of my patients are going to drive an hour in each direction once a week for that care. Most of my patients that most need it, their parents can't even take off work during the day to go to appointments. So I don't know how they're going to take off. If they can't take off an hour to come to my office, how are they going to take off a half a day or a full day to go to Omaha and back for that
Every
camp
week
stay?
for 26
Every
weeks.
week.
Now, that's a lot to ask of any.
And even if it's telehealth, it's how good is that? How valuable is that? How do you build up relationships with these people that they trust you?
Some people say you do.
You do. Sometimes you do. But
Sometimes you don't. I'm sorry, I'm going to interrupt you, but I'm just fascinated by your business model. And then, do you do any remote monitoring of the weight or of these kids or?
We haven't incorporated any remote monitoring outside of portal communication with weight. And then we do have part of our obesity program is an exercise class program. The parents sign up for a minimal fee through there's a personal trainer in town who has a facility that is allowing us to use that, and she helps with the program. And so they can do weight monitoring there, but we don't have remote weigh scales in their homes that feed into our portal or anything.
I think this remote monitoring, Herb, is a cool thing. It's probably a good thing, but it's not quite ready for prime time, at least not in pediatrics. Pretty soon it will be.
I think for some diagnoses, it might be. I think if we have for asthma, it might be great. We worked with a company doing remote patient monitoring for heart failure. And so the idea was, how can we incorporate this for asthma? They had regular check-ins with their smartphones so that we could monitor symptoms and make sure that they were on the right controller therapy. The biggest problem was just patients buying in and actually following through. So that kind of disappeared. But we've worked on that for asthma.
I think Nemours this is maybe 10 years ago, but Nemours was working on trying to get the device manufacturers for peak flow that was digital.
We had
into an app and then to a portal. I do think getting a scale in the patient's home, since they're not going to be able to come every week. And, this is a simple concept of change management. What gets measured improves.
Yeah. That's what our patients do is they call in weekly weights. And if they don't have a scale at home, they can just come to one of our offices anywhere in town. Our offices are all easily well located. Our obesity clinic is run by one of our nurse practitioners. She was really motivated, went out, got a catch grant. And so one of our pediatricians helps her, supervises it. But it's really her baby. She gets all the credit for it. And she's worked with our school nurses too, to do remote or to do weights if they don't have a scale at home. And then is working actually with the school district now to incorporate some of the exercise into the school district because we're having a hard time getting people to show up for exercise class.
Yeah. So it sounds to me, and I wouldn't be surprised, that you probably do ADHD management and evaluations. You probably do anxiety, depression, all the behavioral health, mental health stuff. So it sounds to me that this is a chronic care program that you establish, which chronic care flows right into this value-based stuff.
And then one more question. You said 6 psychologists?
Yeah.
How can you afford that?
It pays for itself.
Wow.
They see the patients. They see patients about 7 patients a day for hour-long sessions, and it pays for itself.
That's great.
And you, through insurance coverage? That's phenomenal. You can do that in Northern Virginia. First, you can find the 6 psychologists because in Northern Virginia, I level set all the time because every city is different in the U.S. Montgomery County is in Maryland, is just northwest of D.C. Fairfax County is just south of DC. And where I live, Loudoun County is southwest of DC after Fairfax. Those are three of the wealthiest counties in the country. And you cannot find a CBT therapist to save your life.
I can almost guarantee you cannot find one that takes insurance because we have plenty of psychologists in Long Island that if I call them up, hey, can you see this patient tomorrow? Is it sure?
No,
they're all on cash.
No, they're all cash. They start at $180 a week. That's not $300 a week.
Yeah.
And even if you have the $300, they have waiting lists.
Yeah.
And that's probably our biggest barriers. We have a lot of patients who don't come in because they can't afford it. But we have enough patients who need it that will pay for it, and they're not, a lot of them are paying for it out of pocket because it goes to their deductible. So they have insurance, but it's not paying for it. And that's probably our biggest barrier. The other barrier is getting testing approved. A lot of times we have to spend a lot of time on testing. But so our model, well, basically about 20 years ago, one of the moms of one of our families was getting her PhD in psychology. She needed to do her clinicals. And so she did it embedded in our clinic as a part of her training. And then we hired her. And then she started recruiting, and we've just gradually recruited people out of the university-based setting, provided them with clinicals when they needed it, and taken advantage of that opportunity. And I would say the psychologists love it because they could go out and hang a shingle, but they like being embedded in the pediatric practice because they have direct interactions with the primary care docs. And they like managing patients with pediatricians better than with psych. Or just throw meds at kids. We really appreciate their input. And I need their input. When Dr. Davies messages me in our EHR and says, this kid's anxiety is not going to be managed by CBT alone. This kid needs medication. My nurse can call and get that kid scheduled for later that week when I have an opening, and we get them on medicine right away. And so having that immediate feedback is great. But the cost is a huge barrier for families.
I have a similar relationship with Dr. Karen Larson here in Northern Virginia, and she's phenomenal. She's a motivational psychologist. Her practice has school psychologists that do the IQ, reading testing, motivation, maturity, because every child is different, so they may be struggling for a different reason. And I love working with her. And she's not expensive. She's $180 an hour. It's the same kind of relationship. She'll call me and she'll say, I saw your patient Johnny. I don't think that a stimulant is good for this kid. Why didn't you change it for Cetera? That seems to work better for this kid with dual anxiety and ADD, ADHD. I've had a whole lot of luck. And sometimes she'll call me and say, you see this patient, other pediatricians seeing them, but they won't listen to my suggestions to switch the meds, and the mom wants to try it. I'm like, sure, I'll be happy to talk to them. Yeah. And the same thing is the adolescent girls who are struggling, they seem to do better on Wellbutrin than any other SSRI. But you can't find the evidence-based medicine to show that. And if you go through REACH, they tell you no, start everybody in sertraline and get them up to 100 milligrams. That relationship is gold.
Let's call collaborative care, chronic care, transformation, the practice of the future, the way it should be.
That's how we do it.
We should get paid more for doing that.
Exactly, because that's my argument. Do you know what? When I do insurance negotiations, all this stuff that we're talking about, that's what I bring up. And it says, RBK should be paid more than Doc in the Box down the street. That doesn't do anything.
So I have one more question as a managing partner, and then we'll move on to
Yes.
But Dr. Hackle says that we are in a state of crisis. The barn is burning in pediatrics. I think we're in an inflection point. And I'm not good with language, but what's the difference, right? I think that the U.S.-based pediatrician for far too long has advocated the responsibility of acting like a specialist in managing chronic care disease. They focused on, there were so many ear infections, pneumonias, bronchiolitis, impetigo, cellulitis, that you could fill your appointment book, see 40 patients, and never treat ADD, never treat asthma, never treat obesity, never treat this, because your schedule was booked.
Correct. That's the way it used to be.
I think we're better than that. So I'd say it's an inflection point, because I think we have to now pivot to the three legs of this stool. We have to do well child exam, which I'm in the minority with my fellow pediatricians. To me, the well child exam is a free opportunity to find disease and address it early. All the other educational components can be done through video or a handout. I'm looking for the BMI change, the blood pressure is elevated, the kid's not doing well in school. What is it that I need to intervene early to change the trajectory of that disease? 2, we have to do acute care. We have to have enough bandwidth where we still can take somebody that's 103 fever out of nowhere, take a look and make sure they're okay.
Yeah, and not just do a panel that tests for everything in their nose and then stick them on clindamycin.
And then number 3, we have to take care of our kids with anxiety, autism, ADHD, type 1 diabetes, type 2 diabetes, obesity, asthma. These are pediatric illnesses. We are the special. Dr. Hackle has a different perspective. He says, we're at the end of the road. The payment has gotten so low that we can't attract enough people to match because they can't afford it. Pediatrics is 70% female.
Yeah.
And the women are burning out at 7 to 10 years after they leave residency, and they want out. But 30% of U.S. physicians overall want to retire within the next 2 years. So he says it's not just a pivot. It's not just an inflection point. We're at a state of crisis. Out of the, I think it's $4.5 trillion we spend in healthcare, we only spend 4 cents on the dollar on primary care.
Correct.
Yet we see 50% of the patient. And we're asked to do more. And how? When you're seeing 30 patients a day, you're not providing quality. You're sticking your finger in the small holes in the dike and hoping that no one gets harmed by it. So in what I call my call to action is pediatricians need to make the same as any other physician, which is $350 a year. It's a lot of money, undeniable. But these kids are coming out with $300,000 in student debt. And they missed out 10 years of an opportunity. There has to be a
And they worked really hard to get there too.
Yes. Right. And there's and I know I'm being ungrateful, and I don't like being ungrateful. I have such a blessed, lucky life. This episode is sponsored by our friends over at Freed AI Medical Scribes. Let's hear what they have to say. What if you could take the computer out of the physician-patient relationship? With Freed, you can. Freed is the AI medical scribe that listens, transcribes, and crafts perfect soap notes for you seamlessly. This isn't just another productivity tool. Freed is a life-altering solution for physicians, helping you regain the joy of practicing medicine. Freed frees you from the burden of documentation, so you can focus on what really matters, your patients. With Freed, the computer is no longer a barrier. It's a quiet assistant that works in the background, capturing every word of your patient interactions, accurately and quickly. The result: you're fully present in each visit, building stronger connections and offering more attentive care. And when the day is done, your notes are too, leaving you with more time to focus on yourself, your family, and your life outside of medicine. Freed is the solution thousands of physicians swear by to reclaim their passion for medicine. It's like a rock star life.
Yeah.
Okay? And it only gets better. I don't know why. I'm just lucky.
Pediatricians are the rock stars of medicine.
But I'm lucky.
Preventive care.
Yes.
Yeah.
To become a pediatrician, a family practice doctor, an endocrinologist, orthopedic surgeon, whatever it is, you give up the best 10 years of your life between 20 and 30. There is nothing can buy you that back.
And for women who want to have children, many of them then delay it until it's difficult for them to have children. You're not able to have their own family or struggle to have a family.
Yes. And I don't like to touch that because I'm a white male and then people get upset.
I'll touch it because I've been there.
You can touch it. But the reality is that woman gives up her best reproductive years and opportunity to find a mate. And so she's 30, out of residency, needs to start working, is huge debt, and now has to find a life partner and build a family as she's building a business. This is a tremendous burden on a human being. I
That
couldn't
is
do it.
correct.
I couldn't do it.
That's correct. But building a business is just like any other business. Ice cream store, card shop, video store, it's all working hard.
No, because you don't have to go through 11 years of education.
You don't start making your ice cream shop at 30.
But you have to borrow money to make the ice cream shop.
But you have
on that. Along with physician, listen, we try to have a good work-life balance. And work-life balance is not just, I want to work 4 hours a day, Monday, Wednesday, and Friday. That's not work-life balance. It's other things. Support, culture, access, or people around it, and the computers and whatever you have in the office to make the physician's life better. My wife is a physician also, and she worked in the emergency room. And we did it. We figured it out. We hired a nanny. We got a babysitter. We had my mother-in-law that lived with us. And she didn't kill me. We just did it. I see people that are the physician, the husband's a physician, the wife's a physician, yet they want to work Monday, Wednesday, Friday. We had a doctor that left us because her husband got a job at one of the local hospitals over here as a NICU person. And she promised that she was going to come back to work with us, yet she didn't. She went to the academic center to work because they worked Monday through Friday. And I said, but we have access on Saturday and on Sunday. Sometimes we all rotate. Who do you think comes to our office for her twin baby checks on Saturdays? Not physicians.
She does, because she's off.
Because she's off, yes.
You know what?
But that's the physician that we're not asking work every Saturday of the month.
You know what, though? I would tell you, George, is that I really think as physicians, one of the first things that we have to do is understand our value, right?
Yes.
There's a shortage of us, and it's only getting worse. So one of the things that I tell young physicians is you have spent all of your academic career trying to prove to people that you deserve to do what you're finishing your training doing. You have to change your mindset now. Your mindset has to be, I have finished my training. I have enormous value. And I don't just have to go and be an employee in a big hospital system and just be a number or a cog in the system. I have enormous value, and I now have enough training. I can do what I want to do.
Exactly. I love it.
That's what I tell them, because I think too many of us start to recognize that 7 to 10 years into practice, like what Herb was saying, right? After 7 to 10 years, they're burned out because they've done more than they were capable emotionally, physically, based on what their demands were, based on what their life goals are. And so then they see it just as I either do it this way or I don't do it at all. And I would much rather keep those physicians in the system doing what they love doing because they'll do a better job. They'll stay in the system longer and we won't lose them. And then we have to figure out how to use all these advanced practice practitioners to do the stuff that we don't have enough physicians to do.
Right.
But we have to put our physicians in their most valuable roles because we don't have enough of them.
Yeah, I agree with you.
My view, that's running the medical team, that's running the medical home. I think it should be running the medical practices. I think it should be overseeing the whole thing. But seeing patients between 5 and 8 p.m., anybody can do that. It's acute care, it's sick care. I can be on call if they have an issue. I don't have to do that. I can do something way more valuable that I have the training and expertise to do.
Yes.
So I'm going to ask you something that you mentioned, which I just love. So in my mind, if we're in an inflection point, we need 3 things to be done. 1, we need to pay physicians well. We need to limit the number of patients you see a day to no more than 16 in an hour day so that you actually can think and do the other things that you're talking about, care coordination, making sure things are done properly. Sometimes a case, I need to sit down and read about it.
Sure.
And then we need to build up workforce capacity, mini fellowships, so that more people across the country can replicate what you're doing with the asthma care, the obesity care, the mental health care, because this is not being taught in the medical schools and it's not being taught in residency. And they've known for the last 20 years that this is a problem. and they haven't changed.
Or they haven't changed. You'll also, what I find with all these...
I want to know how you get to seeing only 16 patients a day, taking a good salary and keeping the doors open.
You can't.
That's what we do in our office.
That's
Now,
why
we don't
Yeah.
limit the number of patients to a certain number per day, but we schedule appointments based on how long the chief complaint or we think the patient is going to take. And a lot of our APs that are doing mostly acute care, especially in the wintertime, they see patients every 15 minutes. But my schedule, some of the appointments are 45 minutes, some of them are 30, some of them are 15. And so we schedule based on what the concern is and give ourselves the amount of time that we need to see the patient. I would say it's probably closer to 18 to 20 for a full-time pediatrician. Some of our physicians use scribes, and that has made a huge difference. I'm very hopeful that AI will do a good enough job to be able to do as much as my scribe does for me now.
I could tell you for a fact that it does.
The one thing my scribe does a ton for me right now that the AI still isn't doing is all kind of the order entry.
Yes, you're correct on that.
Adding problems to the problem list. So when I'm talking to my scribe, I'm like, add this to the problem list, pop in the order for the MDI treatment, do the order for and I'm talking to them while I'm looking something up on Up to Date or looking up a dose of something.
You're correct.
And the only thing that I do on the computer with my patients is show them the growth curve and talk about the growth curve. And I'll look up stuff on their past history and then putting in prescription. And she orders my vaccines. I watch her do it, but she does all of that.
No, AI scribes are very good. My biggest problem was the story taking, the HPI and the plan. That's what should be documented. The scribe that I use really helps
Does
with
a good job. And so I think we're getting there with
it's
that.
getting there.
Eventually it's going to be able to do all of it.
Hopefully.
It won't be long.
So yes, Freed AI is a wonderful solution. It has its hallucinations and nothing's perfect.
Yeah.
But you're absolutely right. If you have the resources for care coordination, that's one side, and also someone that's putting the right BMI in the problem list, the family history of diabetes, so you have to screen that kid. And so all the little things that don't require 11 years of training and they're great at it, then you can do a lot more and not feel overwhelmed.
I want to be the doctor, not the court reporter.
Yes.
That's correct. And so you're
practice transformation. Invented 15 years ago. It just took 15 years to get to where you're at.
I think what practice is what the future should look.
Yes.
And that's why it's fascinating. Because
Yeah.
most people that try to do this, like you, George, you tried doing the embedded mental health, it collapsed because the hospital lost the grant.
Well, that collapsed. The reason it collapsed is the hospital lost the grant. I didn't take enough interest in making it work, and that's why it collapsed. I don't know which one was more important, but now I'm starting to see that it's more important. We have the other stuff, the ADHD, the anxiety, the depression. It's just the speaking part that the doctors don't do. We're going to try to bring that back somehow.
And this is the model for the U.S.-based pediatrician. Because the alternative, which we've talked about, like with Dr. O'Shea, is the pediatrician doesn't see the kids. You have a medical assistant that does the ASQ9, the ASQ developmental, does the growth curve, and if those two are normal, the computer says it's a 2-month visit, they get this, vaccines. I come on in the video and tell the parents, are you okay with it? And then I'm only seeing the kids that don't pass the developmental screen or their growth curve changes. Everybody else is just being run through a clinic. And that's a model that works in Canada, UK, Colombia, Costa Rica, Peru, Ecuador. You don't see the pediatrician unless you're very wealthy.
Well, that don't improve our... Yeah.
So I much rather your model,
Yes,
the future of pediatrics, than the Costa Rica. They do great. Children in Costa Rica have great outcomes.
And we do, I will say, we incorporate, so like anticipatory guidance. We have LPNs and RNs for the most part on the floor, and they do most of the anticipatory guidance and teaching. When I go in the room, I am now developing a relationship with the family and answering the questions for the family that are important to them.
Right.
And a lot of times those questions are brought up by the anticipatory guidance that's done by the nurse, but it allows me to really get to know the family, right? Because I'm spending more time answering the questions that are important to them or focusing my education on the things that I notice that they most need. And so that's a much more efficient use of work than trying to have the pediatrician do everything.
You are correct.
Because
The problem
all
comes
have
in,
to be done by the pediatrician.
but the young generation physician feels that it has to be because that's what they were told in residency and by Bright Futures and by the computer programs. They feel that they have to do their spiel. And until they hit all the 25 clicks and then click it in the computer, they didn't do their job. It's ingrained in their blood.
Yeah, but we have new pediatricians, and
You have to convert them, bring them over to the
It's a bit hard. Most of them are like, "Oh, this is great," because they already, they can focus and build relationships. They don't want to just say the same.
I know. Yeah, I recorded some videos. This is Herb's brainchild to record some videos of the guidance. We send them a text message to Fisher. Please watch this video before you see the doctor today. People watch it, answer any questions. And I get out much faster.
Yeah, for sure.
So now I just want to briefly touch upon what do you think are the biggest challenges you have as the medical leader of such a well-run group?
I think definitely change management. Anytime you change anything with anyone, it's hard. We have 150 members of our staff, if you include nurses, billing, front office staff, and physicians, APP, psychologists. So about 150 employees. And then being split in 4 different locations, communication is hard. And I would say probably our biggest barrier to change management in the last 10 years has been communication. And so we have worked really hard to improve transparency and to improve our communication so that people understand why we're doing things and not just what we're doing. People know ahead of time of what we're doing and that we involve everybody in the change that we're doing, that we find out how it's affecting them so that we can tweak and make changes as we need to adjust. A great example was we recognized we were losing a lot of our acute care patients to urgent care. And there were urgent cares that were non-pediatric that were popping up all over town, and they were not doing a great job of managing patients, and they were overusing antibiotics. And we needed to get those patients back into our office. And the reason they were going to urgent care was because when their kid woke up in the morning with a fever, or when their kid woke up in the middle of the night with an earache, they just wanted to walk in. And so we started a walk-in clinic. And we knew that was going to freak everybody out. How are we going to squeeze these patients into it? So we got a group of people together. And it included front office staff, nursing staff, APP, physician, billers. And we thought it out. We figured out exactly how we were going to do it. And we did a trial run at one of our offices for a few months. We tweaked it again, the Plan, Do, Study, Act cycle. And we reported back to everybody how it was going at that office, what we were seeing, what worked, what didn't work. And now we have walk-in clinic at all 4 offices, and it's going really well. And patients love it. They come in and the first thing they say is, "Oh my gosh, thank you. He woke up last night with an earache." And we were really specific with, these are the chief complaints we will see in walk-in clinic. So if they come in with a chief complaint and it's not one of those chief complaints, we schedule them an appointment and we tell them to come back. So it's earache, it's sore throat. It's really quick things. And it's great too, because I can squeeze one of those patients in pretty quickly, even if I don't have an opening. It makes it pretty easy for everybody. Patients love it. I think the physicians and APPs are loving it. I know the nursing staff are loving it. It's almost a competition to who's going to fit that walk-in.
So I guess she fits into my line, Herb, of primary care when you want it, urgent care when you need it.
Yep.
I need to figure out something for chronic care and services provided by physicians or something like that.
I mean, I want somebody who's listening wants to write me a grant so I can go spend a month in Nebraska studying your practice.
But you know what? It
heredity
has the practice of the future.
Yes, you do.
Culture was established many years ago.
What it should look like. Yes.
But
so I'm going to ask you, because you're on the, I don't even know how to say it, committee for the The PAC committee for
We
the
got so much more to ask.
What is that, and why do you think it's important to be involved? I hate meetings.
So PAC is the Payer Advocacy Advisory Committee.
Okay.
It is for the AAP. And it is a subcommittee of the Committee on Child Health Financing. And its purpose is to advise the AP on issues related to payers and what is necessary for payer advocacy, and then to do some of that payer advocacy work along with AP staff. One of the biggest barriers we have right now is we don't have great connections and interactions with payers. Pediatrics is this much of their budgets, so they really don't pay a lot of attention to it. And so I think that we've got to build up those relationships over time. And the best way to build up those relationships is to show them that those relationships have value to them. And the best way to do that is to collaborate with them. And so as much as I'm sure there are doctors out there, physicians out there listening to this going, collaborate with insurance? What are you talking about? The reality is if we don't collaborate with the payers, they're not going to pay attention to us. And they don't have to because we're this big in their budget. But we can encourage them by people don't want kids to get crappy care, right? So we can encourage them to do the right thing for kids by advocating for them and giving them positive press when they are doing the right things for kids and collaborating with them on programs so that they don't make a mistake too. They got some pretty negative press over the whole MDI flow vent replacement. My kid can't get asthma treatment because my insurance won't cover it. That kind of thing motivates them to do the right thing because they don't want that bad press. They already look bad in a lot of ways to people when they pay their insurance bills.
And I think one of the questions I have for you is because George also sits in that committee, and so does Carrie, and I'm just going to blank out Shannon in Florida. And I always urge you guys to reach out to the Fortune 500.
Yeah, actually,
because the insurance company will listen to Exxon
100%
resources before they'll listen to us.
100%.
That is not only at the national level, because it's a national level. You guys should be reaching out to human resources department.
I agree completely.
That handle benefits for the Fortune 500 and the local level at the top 5 employers in your county.
Absolutely.
And
so
going and
we
visit
talked about that last year at our PAC meeting, is how do we get in contact with the HR professional organizations? Shannon's done that in Florida. We're doing that in Nebraska. And we need to be doing that nationally because the HR groups, and this is the big topic at our meeting last weekend, the HR groups are making decisions on what will be covered by their ERISA plan. But also, if they're not going to do self-insurance, what do we want to make sure is covered? What are we asking these insurance companies to do? And so that's where it needs to come from because they're the customers, right?
Hey,
The patients are the customers, but the employers are the customers because the way our system is set up, they're providing the insurance. So we need to be educating them. I love Christoph Diasio's idea of the good housekeeping stamp of approval from the P on this plan covers the things that it's supposed to cover and pays adequately for us and will allow pediatricians to take good care of your employees' children. That's what we should be doing. And I love that idea. And hopefully we can start to push a little bit. So
here's another
maybe we need to change the name of our committee.
Yeah. So here's another
a lot of people look at the people that are on it. You have Sean, you have me, Carrie, Susan, Crystal, Shannon, a lot of people, a lot of heavy hitters, lots of experience.
Another push in that area is remember the people that run these departments are business people. Their pain point is how much it's costing them to insure their employees, which it's gone from $27,000 for a family to $37,000 on the average. And when you talk to them, you also have to say, look, payer, I'm going to just call him payer A, is a national payer. In many markets, pays independent practices less than Medicaid, which is not sustainable.
It's not sustainable. And it's not
bad. But they will pay your local health system 200% of Medicare. So once all of the private practices are gone, your costs are going to quadruple.
Yeah.
because you're self-insured. You need to get on your payer to make sure that there's enough competition in your market to keep your prices down. Otherwise, you're just going to keep raising the amount of money they're taking out of your pool to pay for this. They will listen to that message because they're tired of how expensive it is to provide these services for their patient, for their employees. And to them, they can't drop it because they need that to recruit the best of the best. Not only do they have good salaries, but they have great benefits. And that's what the best of
And
the
that
best.
takes us to where we really should be going and in primary,
We are.
I think, which is direct to employer.
Okay, yes, that's a whole other model. And yes, that I love that idea. So we have a slight disagreement on this.
I don't think we're going to be able to get to it because
Yes, we
I'm
are.
not
have to
speaking
go
for
to
3
a-
minutes.
Um,
I have to call her back for the second.
No, we're going to
early
just do this
part.
quickly. Okay.
And do it in 3 minutes.
When I hear value-based care, I hear Obama era, we can't afford to pay for Medicare in the hospital care, in the emergency room. We need to transfer that into the primary care office, decrease the amount of money we spend on chronic illness. And our end goal is to decrease the amount of money we spend without doing harm. That is not possible in pediatrics because we're down to the bone in what we're being paid. And pediatrics is about investing in the future, and not in the future of this quarter, next quarter, not even 2 years. We're investing in the next 20 or 30 years.
Correct.
So try to find a formula to capture that is very difficult.
It's very difficult.
But I think you have a different idea of what value means. What is that idea?
So value-based care is looking at cost spent, right? And what value you're getting out of it. But I think the difference in my viewpoint is it still applies to pediatrics. You just have to lengthen the amount of time that you're talking about the value, okay? And so we're not talking about the value to your bottom line in the next year. We're talking about the value to the whole system. And that may not be measurable in dollars per year, right? That's measurable in employability, somebody actually being successful and not dropping out of high school, someone not ending up in a substance abuse program, preventing childhood trauma. All of the things that we do in pediatrics have value, but they have value over the lifetime. So if we're talking about an 85-year-old, we've got short-term value, high cost. If we're talking about a pediatric patient, we've got long-term value, low cost over the course of that time. But the preventive care that we do in pediatrics is expensive, especially vaccines, for example, right? And the time that we spend with families doing education and trying to prevent trauma, the mental health care that we do, it's all very time intensive. The reality is we have to measure that value differently. So I believe that value-based care and paying for valuable care is the right direction to go in pediatrics. It just can't be based on annual shared savings. This idea that annual shared savings is going to be the way to fund care isn't workable in pediatrics. But you can still have value-based programs that you're paying for, whether that's recognizing that groups have integrated mental health care and paying them more for it, whether that's paying someone a lump fee to do all the preventative health care for a patient for the whole year, and then making sure that they're getting those patients in and actually caring for them. And I resent some of the implications out there. Oh, we can't do that because then people will just take the money and not see the patient. We're the physicians. We're making the decisions to take care of patients, even though we're not getting paid adequately most of the time. I really am not worried about pediatricians not doing the right thing. Maybe a private equity-owned company that's telling pediatricians they have to do that, but in physician-owned, physician-run companies, if you gave me the dollars to do all the preventative health care for a family over the course of that year, I could spend it ahead of time on care management. I could do it more efficiently. I wouldn't have to necessarily bring them in for every visit, depending on how things were going. I could do so many things to take better care of those patients. And that to me is value-based care.
So
Capitation.
no, it's
It
not.
is called capitation.
I don't know if it's perfect or not. But what you're saying
Ways
is,
of having capitation run. The way we've done capitation in the past,
yeah,
it didn't work.
It's a small amount
But
of
if
money.
you're talking about just the preventative care piece, right? Then I think you can do it. And then you have to risk stratify appropriately. And that's a hard thing to do. I think that's going to be our biggest stumbling block is risk stratification, especially when it comes to things like social determinants of health and resources for families.
Yeah.
That's a hard thing to quantify.
Yeah. And then how does this look in Nebraska? Because in the East Coast, it's all about decreasing spend or share savings.
And I'm going to have to do this later. I have to go.
Okay. We'll just welcome you back. We have to.
You just got to my favorite part.
Yeah.
I love talking about what we
So
do.
we'll do episode 2.
Yeah, we'll do
Episode
episode 2 whenever you
We
want.
have to change the title because the first hour is like nothing about value.
Well,
Yes,
you're already there. You're providing value. We need to show people how the future looks, and the future is you.
yes. Yeah, no, we need to
That's the amazing story that we were missing on the show notes. That is the amazing story to be told.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.